Good morning, Chairman.
Good morning, Jess. Good morning and welcome to the meeting of the Adult Care and Public Health Scrutiny Committee. I am Councillor Jimmy Brooks, the Chair of the committee, and sitting to my right is Vice Chair, Councillor Maggie Cullen. In addition to welcoming the members of the committee, I would also like to welcome Councillor Steve Clegg, Executive Councillor for Adult Care and Health. Before we begin, there is a standard announcement. If you hear the fire alarm, please exit through the rear doors into the reception and into the car park and wait further instructions. The audio-visual feed of this formal public meeting is being broadcast live via the County Council's website, and all your comments will remain accessible online. Please have all mobiles, laptops and tablets on silent mode. The hearing loop is now activated. Requests to speak will be collated by the top table. Please indicate early when you wish to speak. We will now move on to the formal agenda. Agenda item 1, apologies for absence and replacement members. Jess.
Thank you, Chairman. Today we have Councillor Carey replacing Councillor Redfern and Councillor Hume replacing Councillor Litchfield. Thank you.
Thank you very much. Agenda item 2. Do we have any members wishing to declare an interest? No. Lovely. Thank you very much. If anybody is wearing a jacket, please, if you want to remove it, please do, because it is quite warm. Agenda item 3. Minutes of the Adult Care and Public Health Scrutiny Committee meeting held on the 3rd of June. This item is to approve and sign the minutes of the meeting as a correct record for accuracy of the previous meeting. Please turn to pages 5 to 10 of the agenda pack. Inaccuracies can be corrected, but if there are any questions of content of the minutes, members can contact the officers outside of the meeting. I'm assuming everybody's happy they are accurate. Do I have a proposer? Councillor Reeve, do I have a seconder? Councillor Bean, thank you very much. Could I have a show of hands, all in favour? Any against? Any abstentions? No, that is agreed as a correct record. Thank you very much. Agenda item 4, minutes of the extraordinary meeting, Adult Care and Public Health Scrutiny Committee meeting held on the 8th of July. This item is to approve and sign the minutes of the last meeting as a correct record and that they are accurate from the previous meeting. Please turn to pages 11 to 14 of the agenda pack. Thank you very much. Do I have a proposer that these are a correct record? Councillor Carey, do I have a seconder? Councillor Reeve, could I have a show of hands in favour, please? Any against? Any abstentions? Just one abstention. Thank you. Those minutes are agreed as a correct record. Sorry, Councillor Cook.
Thank you, Chair. Apologies. On the previous item for the minutes of the standard meeting, I was trying to find the agenda on my laptop and I missed it, so I can I express a vote for those minutes, please? But obviously abstaining because I wasn't present for the extraordinary one. Thank you.
Yeah, no worries. Thank you, Councillor Cook. Are you happy with that, Jess? Thank you. Agenda item 5, announcements by the Chairman, Executive Councillors and Lead Officers. I would like to report that I recently attended the Lincolnshire Care Association conference on the 15th of July. Lincoln plays an important role in representing and supporting independent care providers across Lincolnshire, bringing together leaders from all adult social care sector to share innovation, best practice and solutions to the challenges facing care services. The conference provided a valuable opportunity to hear about developments within the sector, celebrate excellence in care and strengthen relationships between providers, partners and public bodies. I would like to extend my thanks to Lincoln for the opportunity to engage with care sector representatives and to also thank them for their continued contribution to improving care and support for residents across Lincolnshire. I also gave a report to the executives last month. Was it last month? No, this month, I do apologise. This month, and the leader asked to pass on his thanks to all members of the committee and thank you for your scrutiny. Just to note, I possibly be having a break after agenda item 7, depending on how we go. I will now move on. Councillor Steve Clegg, is there any announcements?
Thank you. Yes, there is, Chairman. I, like you, attended the Lincoln conference a couple of weeks ago, and yes, it was a fantastic meeting event. They're a great group of people. I won't go on further, but again, like you, pass on my thanks to them. The day after that, a couple of weeks ago, this is now, I attended the opening of Grange House in Market Raisin, and that really is a fantastic community-supported living development that's literally just opening its doors as I speak. The intention is to give people with disability the opportunity to live independently with dignity, and of course the support they need to enable them to thrive in their own community. I was aware of all of that obviously before I actually came and attended that opening event, but excuse me. Fortunately, whilst we were there, I managed to meet a young man who just moved in and speak to him and his mum and dad as well. And I think this really just brought the whole thing to life for me. You could see on his face just how incredibly proud he was. He's just moved into his new home, and equally importantly, his parents, his mum and dad, were just so pleased to see that this young lad was now taking another step in growing up, if you like, and gaining that greater independence, whilst they being obviously confident that he'd get the support he needs to enable him to do exactly that, and to build new friendships as well. So that was really important to me. And we need more schemes like this in Lincolnshire. I doubt anybody would disagree. I would hope nobody would disagree with me regarding that. And so that's the end of my announcement. Thank you.
Thank you, Councillor Clegg. Martin Samuels, Executive Director for Adult Care, or Martin Parker. Are you just yourself? Martin Samuels, thank you.
Yeah, Joe, if I can just make a couple of quick announcements. Obviously, short breaks is something that we've spoken about quite a lot, and I thought it'd be helpful for the committee just to give a quick update on where we are with the consultation process with individuals and their families who can or could draw on the short break service. So members will be aware at the last meeting, the extraordinary meeting that we had, I noted that there were 124 individuals who do or could access the service, and said that we were working to engage with every single one of them, and I thought it would be helpful for the committee just to give a quick update on that. So of the 124 people, we have now been in contact with 119 of them. The remaining 5, we have made repeated efforts to contact them. We have emailed them, we have phoned them, we have written to them with no response. We are thinking about whether it be worth literally someone popping round for those 5 just to make sure that they are okay, and that they are aware of the opportunity to engage in a consultation. So 119 have been contacted. And had a conversation. Of those, 51 said that they wanted to have to take up the offer of a social worker having a one-to-one conversation with them in order to go through the consultation process, so that they could have a full involvement in the consultation. The reasons for others declining the offer, many said they were either quite happy to fill in the consultation themselves online or had already done so. So of those 51 who have said that they would like to have a face-to-face, a one-to-one conversation, all but 5 of those, so 46 of the 51 have now taken place. Councillor Clegg had made a commitment that he would like to observe as many of those sessions as was possible, obviously subject to the willingness of the individual and their family for that to happen. That has happened for about a quarter of those interviews, and I should say that through my staff system, I've had a number of comments come back about how pleased members of the public were, and indeed how pleased the staff were to have that involvement from the executive member. More broadly, we've now had 275 submissions through the website, and that will include those that were facilitated by the social workers. 119 of them, it's a coincidence in the number, 119 of them are from individuals or families using the service. Most of the rest are from the general public. There are some staff and some advocates. Consultation is now just over halfway through, so we're still collecting information, and the collation and analysis of that of responses will take place after the consultation finishes at the beginning of September. But that process, in terms of people who are or could use the service, we are very well on the way in terms of engaging with them. And then a very quick second update. Members of the committee will be aware that my deputy, Hayley Eccles, underwent major surgery a few weeks ago. And I just wanted to give a quick update to say that I've been texting with her just recently, and she tells me that she's recovering well. She's naturally tired, but is definitely on the road to recovery, which is very good news, I'm sure, that all of us will welcome. Thank you, Chair.
Thank you, Mark, and pass on the committee's well wishes to Hayley, because I'm sure that everybody would want to do that. Thank you very much. We'll now move on to the next item, agenda item 6, Adult Social Care, Care Quality Commission, CQC Assurance, and East Midlands Association of Directors of Adult Social Services Peer Review and of Safeguarding Assurance. This scrutiny report can be found on pages 15 to 32 of the agenda pack. The committee is invited to consider and comment on the report and to note the update of the Quality Care Commission Local Authority Assessment process, note the findings and learnings arising from the East Midlands, is that ADAS? I'm assuming it is, Martin? ADAS, yes, thank you. Peer review, note the alignment between the peer review findings and the Adults Improvement Programme, and to note that the verbal update on the final CQC assessment report will be provided by the Executive Director, subject to publication. Over to you, Martin.
Thank you, and I think Jess is going to be able to put up some slides for me. Clearly, this isn't quite the update that I was expecting to give you, because we had, at the point where we wrote this paper, we were expecting that the CQC report would have been published, and it hasn't been, and I am still awaiting further feedback from CQC, which I'll come back to in a second. And I should note that I think we are working on winning the competition for having the longest report title in the history of the Council, so apologies for that. So if we go on to the next slide, please, that would be really helpful, Jess, thank you. So I'm going to quickly talk a little bit about the CQC Local Authority Assurance pilot and our response. I'll say a little bit about where we are in terms of the region, and I'll then focus more on the East Midlands ADAS peer review, and then some of the highlights from that and what we're going to do next. So it's a small number of slides. I hopefully won't talk too long. So if we move to the next slide. So members of the committee will be aware that in 2023, the government asked the CQC to start assessing local authorities for really that function hadn't been assessed for getting on for 15 years, and so the government asked the CQC to do that, and the CQC recognised that this was a completely new function for them, and therefore rather than simply launching in, it would make sense for them to run a pilot exercise. And Lincolnshire was one of 5 authorities that volunteered to take part in that process, and indeed we were the very first to be assessed, with the site visit taking place in 2023. The pilot was exactly that. It was testing methodology, and CQC were very clear that they had materially changed their approach and their scoring arrangements following that pilot process on the basis of the lessons that had been learned, and therefore although they haven't stated this publicly, they have repeatedly in meetings and privately confirmed that the assessment and the ratings from the pilot are not comparable with the subsequent process, what they call the baselining process, which they've taken every authority in the country through. And in a sense, the fact that's been underlined by the fact that they have then included all of the 5 pilot authorities in the baselining assessment, so come back to reassess them, I think underlines that the assessments from the pilot were not considered robust, or at least not comparable. Despite knowing that this was a pilot and therefore that it wasn't the most robust of processes, we very much looked at what the CQC said in their report, and I've listed there a wide range. I'm not going to go through them, but there are a wide range of areas where we have been actively working over the last 3 years, it is now, to improve and address the issues that the CQC identified. So if you move to the next slide. So having done the pilot process, the CQC then began what they called their baselining process. So in effect, the first assessment of every authority in the country, including Lincolnshire and the other 4 pilots. So they have 4 key lines of inquiry, which are listed on the left-hand side of the slide there. Slightly confusingly, in the reports, those are actually expressed in 9 different categories, and there's not a direct read across from the 4 to the 9, but that's the way the CQC work. And then they have a highly mathematical, arithmetical system of working out the scores. So essentially they provide scores in subcategories, which then sum up to scores in the 9 categories, which then sum up to a score overall. So it is an absolutely mathematical process. They don't apply any judgment to the score, which I think is worth noting is in sharp contrast to the way that Ofsted, for example, work with children's services. And that therefore means that they run the numbers through a calculator, and it produces an overall number which then directly relates to a rating. And I've put on the right-hand side of the slide there what the numbers are. So that's how the rating system works. If we move on to the next slide, all of the reports for the East Midlands have now been published, other than that for ourselves and Rutland. So I've listed what the scores have come out for the rest of the region, and you'll see that of the 8 authorities that have been published so far, we've had 6 come out as requires improvement and 2 have come out as good, but there's a sort of clustering around that requires improvement good area. So that's where the region is. So if we then move to the next slide, and a little bit about what's been happening in Lincolnshire. So, as I say, we had the pilot assessment summer 2023. That was published in November of 2023. CQC deliberately wanted to publish all 5 pilots at the same time, and as I've already said, they later privately confirmed that the pilots wouldn't be referenced in the baselining process because it was a substantively different process. So we were then put towards the end of the baselining process. So through September through to December of last year, there was a significant volume of activity. They were only on site for a couple of days. That's again their methodology, but for months we were engaged with them. We provided them with hundreds of documents, large amounts of data. They undertook a number of interviews. They didn't look at many cases. Their methodology isn't very based. So again, whereas the Ofsted methodology is based on inspectors looking through hundreds of cases, sitting with the social worker, basically going through that social worker's entire caseload in detail. CQC work on a very different approach, where essentially they look at reports and data and they interview people, but they don't really look at the lived experience of people by looking at individual case files. They then went away and produced a report. This took significantly longer than we had been originally led to believe. So we'd been told that we would probably expect the report sometime in February. It actually appeared in April, and that was a draft report and a draft score, and we were then invited to look at the factual accuracy of that report. I think it's worth saying that the CQC, I think it's well known that the CQC has had a number of issues over the last few years in terms of the quality of its reports. right across the board, not just with local authorities. It's therefore quite common for there to be a significant number of queries raised about the factual accuracy of the CQC reports. However, the level of factual accuracy issues that we identified was unusual even in that context, and indeed we, on a draft report that was, I think, about 45 pages long, our factual accuracy comments were over 100 pages long. So in fact, our factual accuracy was about as long as the report itself, if you allow for the template. CQC's process gives the receiving organisation 10 working days to respond to that report, which we did. So we produced that 100 plus pages within the 10 working days. It was, I think, a credit to my team, a number of the members, the individuals sat around me, but a number of others as well, that we managed to provide a comprehensive response in that very limited amount of time. CQC work on the basis that they normally would take 10 working days to respond to those factual accuracy comments. We actually received a revised report on, I think it was working day 36 that they responded. They took just about all of our factual accuracy comments on board and changed so the revised report was significantly different to the original report. Nonetheless, when we looked at the revised report and the responses to the factual accuracy, we identified several areas where there were contradictions and inconsistencies between what had been done, and we have therefore already taken the next step, which is to request a formal review of the report. Of an element of that. It's a very, very tight process. You're allowed 500 words to point out queries. So we have in fact already submitted that. CQC have acknowledged receipt of that. Although again there is a limited time period in which we're allowed to submit that request, CQC do not set themselves a timetable for them responding to it. So we are in process. We had been expecting the report to be published on Friday of last week, but when the CQC received our request for a formal review of the report and comments that we had made about certain other aspects of the way they were handling the situation, they decided to pause publication. And we are awaiting their response. My instinct is it'll probably be another week or two, but given the length of time that it's taken, it could be another month or two. I'm not in control of that process. So really, there isn't an awful lot more that I can say about the CQC process, other than to repeat the offer that's been made previously, that we are very happy to do a confidential briefing to members of the committee, either on the day of publication or a couple of days later, if members would prefer to have a couple of days to read the report and then consider it. And then we would bring the published report and our response to it to a future meeting of this committee. And again, if the committee wanted to have an extra meeting, we will do whatever the committee would like. So if I move on then to the East Midlands ADAS safeguarding peer review, which I can talk about because that has been done. So one of the things that so ADAS is the Association of Directors of Adult Social Services, so it's my professional network, and the East Midlands branch runs a process of peer reviews. Most regions do this, where there is an expectation that every authority across the region will, on a 2-year cycle, both receive a peer review and be subject to a peer review, and will also contribute staff to lead peer reviews in other authorities. And the aim is that we are maintaining that self-awareness, self-critical learning process. And I should say also, it's an extraordinarily powerful learning experience for the people who do the peer review. So I've led now 3 peer reviews within the region, and I've led peer reviews in a previous region I worked in as well. And I know that for myself and the staff that undertake those reviews, going into another authority, seeing what they do, seeing how they're different, is really, really interesting, and there's a great deal of learning. So that the reviewers learn as much as the reviewees. And the whole process is intended to support our ability to be focused on our local residents and to be ready for CQC assessment. The process is a very rapid process which involves some online team-to-team sessions of social worker with social worker to some element of looking at case files. In fact, I think in our peer reviews we look at more actual cases than the CQC do in their inspections. We have a mystery shopping exercise and a review of the website, and then we have an on-site session, normally a day or two. So we're really triangulating the different sources, and because we focus on a particular issue, and in our instance we asked that it focus on safeguarding, I think that our peer review process is actually probably more rigorous for that specific element than the CQC process is, which, because of course that looks at the whole of the council. So if we go to the next slide, summary of the findings there. I'm not going to read out the detail there, but essentially they identified a number of areas of strength detailed in the text there, but they also identified some areas where we could be more effective. Greater ownership across partners of safeguarding, so that we don't have a situation where partners think safeguarding is the council's responsibility, safeguarding is everyone's responsibility. Issues about simplifying some of the routes and thresholds, having a more effective assurance process for treating provider concerns, and the like. So a range of areas identified for us to both as strengths and areas for us to improve on our performance. So if we go then to the next slide, again, members of the committee will be well aware that we have an adults improvement programme that's been in place now for about 18 months or so, and that has a number of work streams in that, which are set out on the slide. I've been very clear that it would be confusing for us to have a CQC improvement plan, a peer review improvement plan, a XYZ improvement plan. So we've been very careful to have a single improvement plan, which we have been taking forward, and worth noting that the draft report from the CQC repeatedly comments about the progress that they saw, that the improvements that they have seen over the last couple of years, which can be, I think, very closely linked to the Adults Improvement Programme. So we've been taking that as our programme and taking it forward, and of course we will continue to report on the delivery of that programme to this committee. So if you go to the last slide, and I will be done, Chair. I know you're starting to give me the eye because I'm taking a little bit longer. Worth noting that we continue to work with the CQC to support the development of their assurance framework. So the next stage is they are developing a system called annual assurance meetings. One of the things that I think has been I and many other DASs have found a bit strange was that at the point where CQC published their report, their pilot report on us in November 23, there was then no contact whatsoever from the CQC again until the point where they contacted us in the autumn of 2025 to say they were coming back to inspect. The CQC had no engagement, no relationship, no monitoring, and they've realised that that's really not a very sensible way to work, and they've now said that they're going to have, as I say, an annual assurance meeting, and slightly madly I've volunteered LCC to be one of the pilot authorities to work with them on that, and we are currently arranging for that to take place in September. I've talked about the Adults Improvement Programme. We are going to be, we're already looking at the I suppose it is still a draft report, and building that into the Adults Improvement Programme so that we are well ahead of issues. Similarly, with the peer review, we're building that into the Adults Improvement Programme, so there'll be a refreshed approach to that, and that will take into account of all that. And then, of course, we're slightly from a different angle, but of course, LGR, we can't have a meeting now where we don't talk about LGR, local government reform. So we are now also looking at what the implications of LGR will be for the improvement process. And the final thing that I'll say is CQC work on a basis that they would expect to inspect councils every 2 years. They're on a 2-year cycle. Therefore, in theory, we would expect them to come back in December 2027. They have very recently, just in the last week, said that they will not inspect any reorganised council within 6 months of vesting days. So they won't. So the 6 months before and the six months after. And worth noting that whatever the final report says on Lincolnshire County Council, when it does get published, that rating will disappear at the point where LCC disappears, and as far as CQC is concerned, there will be 2 completely new councils that will need inspection and baseline inspection for the first time. Based on what CQC has said and the LGR implications, my instinct is that they might well want to re-inspect us in the summer of next year, but that is purely a instinct on my part, and it might well be that in fact they decide that they will come back late 2028 instead, and I think it will very much depend on other councils and where they are. So I'll stop at that point, Chair.
Thank you very much, Martin, for that report. And I do love a good PowerPoint. Thank you so much. I would now like to invite members to comment and ask questions. Councillor Cullen, Councillor Reeve.
Thank you, Martin. I'd just like to first of all say thank you very much for the work you and your team are doing and the tolerance that you're showing towards the CQC. I do agree there needs to be a government body that looks over everybody and sees how we're doing in relation to other councils and keeping an eye on things so that it's not a problem. And I don't expect you to comment on this, but I do find it quite worrying that nothing about the CQC has impressed me, and I just think they are failing in themselves, particularly when they're supposed to be the body that makes sure that we're not failing. And I just want to just say that thank you, because how you're keeping cool and dealing with it all, I really don't know, because I don't think they're fit for purpose, whereas I think you're doing a great job, so thank you.
Thank you very much. Councillor Carey.
Thank you, Chair. Mine's a quick one, basically. It's regarding the safeguarding peer review. The review has identified complexity at the front door. So what practical changes will residents and carers notice with the results of this review? Thank you.
So the ability to make a safeguarding referral easily is really important. Equally, we need to make sure that those safeguarding referrals are robust referrals, and we're in a position where the number of safeguarding referrals that is being made has been and is increasing rapidly. We don't think that that's due to any significant change in the level of safeguarding within the county. We think it's a reporting issue as opposed to a real change issue. And we do think, just picking up the comments, Councillor Reeve's comments about CQC, we think this is in part driven by the CQC, where they have been saying to providers, not sure that you're making enough safeguarding referrals, not sure if you were quite right in judging whether that was or wasn't, which is encouraging providers to say, well, could be a safeguarding review, we'll bang it in. And I'm reminded of a comment that a colleague of mine some years ago said to me. He said that if you're looking for a needle in the haystack, you don't normally start by making the haystack bigger, but that is exactly what the system is doing. So we're, on the one hand, we wanted to make it easy for people to make a safeguarding referral, because we need to know, we don't want people to be put off. But equally, we want to make sure that when they do make that referral, there's enough evidence in there so that we can actually investigate it, and we don't have. And we're finding that actually only about 1 in 6 safeguarding referrals is of a level where when we've looked at the evidence, that it merits it actually being investigated. So 5 out of 6 don't. And given the numbers, that is a very, very large amount of work. So what we're working on is and it's that sort of fine line. We want to make it easy for people to make a referral, but we want the process of referral to collect the information. So we can't have a situation of Mr. Jones ringing us up and saying, "I'm really worried about my neighbour, Mrs. Miggins. I think she's being, there's a safeguarding issue. Could you look into it?" Put the phone down. There isn't really anything we can do with that. So we're trying to have a process, and I should say most of the safeguarding referrals we receive are from professionals rather than the public, and that's as you would expect. We're trying to have a process which is a streamlined process, but nonetheless a rigorous process, so that professionals need to say why they think there's a safeguarding issue, what it is, what they have done, because, as I said earlier, safeguarding is everyone's business. It's not the responsibility of the council's safeguarding team to keep everyone safe. It is everyone's responsibility, but there may be additional things that are required. So we are trying to do that, and what we should find when we get this, as we get this right, is that people who have concerns find it easy to report them, and that we're able to identify at an early stage where there are concerns and take the necessary steps.
Thank you very much. Councillor Overton.
Thank you very much, Chairman. Thank you for all your hard work there. Clearly hair pulling, and certainly you've stuck with it, which is really important. I think we're arguing the case because we feel that we're being misjudged by the process not being robust and secure enough. Just for the record, are there some things in the improvement plan which people might recognise, for the public might recognise, about the impact of how we're making things better for people in the street? It's a bit following on from the last question. For people listening, they can hear all the discussion about process, but are there some things that you could just raise that will give people confidence in the improvement plan? Thank you.
So if I start, and I might call on Martin who runs the improvement program for me to pick up, but just so things that people would notice. So one of the key elements of the Adults Improvement Programme has been the strategy, which came through this committee for consideration and then went to the executive to be adopted at the start of the current calendar year. Central to that is our target operating model, which sounds a very theoretical, conceptual thing, and what difference is it going to make to people? Well, it makes a huge difference to people, because it is shifting the mindset of, there's about 1,000 staff in the directorate. It is shifting the mindset of those staff from a position of reacting to, oh, Mrs. Miggins has contacted us because she's having some difficulty, well, let's put a package of social care in, to a mindset that says, well, we've got an understanding that there are communities within our county where there are people who are struggling. What is it that we can do in those communities that make it easier for people to maintain their independence? So we're having a much greater focus on preventative services, on working with the voluntary sector, on services that can step in quickly when someone has a crisis, rather than the ambulance crew coming and taking them to hospital, and we're then left with a person who's been in hospital, who's decompensated and lost ability in hospital, and we're then having to put in services to support them. Instead, we're getting to them quickly so that they never go to hospital in the first place, and that they're able to stay at home and maintain their independence. So what individuals will see and are seeing is a more responsive service that gets to them at an earlier stage in their development. in their development of needs, and is really focused on them having an independent life. So again, part of the shift is starting with what is it that someone can do for themselves already, and how can we support that so that they can maintain their independent life at home, rather than saying, oh, Mrs. Miggins is finding it a bit difficult, well, let's arrange a care home placement for her. So people who previously would have gone into a care home are now being able to stay in their own homes, in their own communities. And not only is that hugely important for people's quality of life, no one grows up looking forward to going into a care home. Not that I'm knocking care homes, they do a fantastic job, but for the people they need to. But I'm always very conscious that adult social care is and always has been a means-tested service. And if we are prescribing more care for people than they actually need, they are having to pay for it. And so and if people have, again, one of the things that is very closely aligned with people's ability to maintain their independence and maximising their staying at home is having money. So if we're not taking the money off them to pay for care, they're able to look after themselves. It makes a real difference. So there are people now living at home independently who would otherwise be in residential care. So I see that as a significant impact for people.
Yeah, Councillor Overton.
Thank you. Just to come back on that, absolutely support that direction. It's not a new one for us, and I heard it's actually also what Louise Casey was saying this morning on the radio, I think, about more care in the community, and that the number of community workers has actually decreased significantly from councils over the past few years, and that she said nationally. But I think when I looked at the figures. Over the years, we do get those performance figures as to how many people are in homes compared to the population effectively. We've not been high in Lincolnshire, relatively, I think, compared to the other council areas. So I think it's absolutely good, but I don't know how much more we can do. Are you thinking of getting more community workers? What are you thinking about? Thank you.
So just to pick up on that, so in terms of residential care, if you are a working age adult in Lincolnshire, you are significantly more likely to be in residential care than if you lived in one of our comparative statistical neighbour authorities. If you are a older person over the age of 65, you're about average likely to be in a residential care compared to our statistical neighbours. So we are a very, very low spender in terms of older people. Nationally, in fact, we're one of the lowest in the country. We tend to be either the lowest or the second lowest. We have about an average number of people in residential care. We are a slightly high spender in working age adults, and you are, as I say, much more likely to be in residential care than elsewhere. So I think there's a long way for us to go. In terms of community staff, I think there's a couple of issues there. Community staff in the NHS have been massively reduced over the last decade or so. The number of district nurses is very significantly lower than it used to be. That has a really quite significant impact. The NHS has grown in hospitals, it's shrunk in communities. It's certainly true that councils have reduced their preventative services. A previous council I worked in had significantly reduced its preventative services about 15 years ago. It then saw the fastest rate of increase of care packages in the country over that period, such that I think they were in a position of having almost the same number of people in care as Lincolnshire does for a much smaller population. So there's quite a lot still for us to do.
Thank you very much. Councillor Lee.
Thank you ever so much for your work on this, Martin. It sounds like it's been so frustrating. It really does, as my mum would have said, like knitting with spaghetti. And I recognise some of what you've said about preventative care as well, because I helped look after my mum, and that thing where she'd have had just a bit more support, she wouldn't have ended up in a nursing home, which cost £36,000 for 15 months. It's just ridiculous. And just to say, I'm glad I've happened to have glanced at the news this morning. The PM's announced a focus on social care, and I'm really pleased about that because it does impact on the NHS. I've seen that firsthand, but I'm pleased too that he's talking to other political parties, the major political parties, so that whatever happens, it's work there's a plan and it carries forward, because this is a can that's been kicked down the road for so long, and it impacts on all of us. So I've got really high hopes, but just keep fighting the good fight.
Thank you very much. Councillor Woolley.
Thank you, Chairman. So I think it's a question to both Martin and indeed Councillor Clegg. And it's around the inspection side of things and trying to tease it out. Martin, are you aware of other councils that are sitting waiting for a report? It just seems a phenomenally long time. If it is a phenomenally long time waiting for the CQC report to come out, have you registered any concern from either yourself or indeed ourselves about the length of time that it's taking? And likewise to Councillor Clegg, have you been in touch with the Department of Health and Social Care to say, you know, how on earth, you know, on a practical matter, how on earth can we get on improving ourselves, regardless of what's said in the report, if we don't actually know what's in the report to improve on? And that doesn't just apply to officers and those at the coalface. That does actually apply to the public as well. How do they know what good is meant to look like if there is no information in the first instance on what you're hoping to either improve upon or whether you may even need to step back from? So both of you, have you written letters to the DHSC? If you haven't, are you going to?
Thank you very much. Martin?
So we haven't written yet. So the length of time it's taken for our report to be published, and of course it hasn't yet been published, so the clock is still mounting up, is some distance longer than average, but it's not massively longer than average. So CQC have been quite behind. So North Lincolnshire, which was again one of the pilots, they had their baseline inspection, I think, the week after us. Their report hasn't been published yet either. So North East has, but North hasn't. Yep. Yep. So CQC have said that they trying to do 153 reports in 2 years from a standing start, they always knew was going to be difficult. Ofsted do it over a 3-year cycle, not a 2-year cycle, and they've been doing this for donkey's years. So it was a demanding process. The process they've chosen to take is a very lengthy process. But yes, to be getting on for a year from the point of starting the inspection process to the point of report being written is not terribly encouraging. I don't think will be the longest period for any council in the country, but there won't be many longer than us. I have spoken with the Chief Inspector previously, and I think when this process has finished, we will be making representations. CQC has now very recently appointed senior individuals to act as liaison with council. So as I said earlier, one of the really odd things was that they made, it wasn't part of the CQC approach to have any kind of relationship with councils. They would just land, do the inspection and disappear and then land again subsequently. They have now appointed a series of deputy directors across the country to develop a relationship. So ours has just recently been appointed. She covers East Midlands and Yorkshire and Humber. And so through that relationship, she'll be the one doing the annual assurance meeting. I will be raising the concerns about, look, this is, I mean, it's just out of date now. And that's the problem, that there is so much that of what they saw and what they looked at, which was autumn of last year, well, that's, you know, we've moved on. So it is a weakness in the process. I mean, I think Martin wanted to come in on a couple of the points that were raised earlier, if that's okay, Chair.
Yeah, I just wanted to give some practical examples on what people will see different from what Councillor Overton said. So whilst Martin gave us that kind of broad overview, in practicality terms, what will they see, feel, experience? One of the key things is, and I think this again was on the news this morning, is about people being heard and people being listened to. So we're doing a lot of work, and Chris, who's sitting behind me, is the principal social worker, is doing a lot of work with teams to make sure that that strength-based approach is consistent across all practice. So people should start to feel a more strength-based conversation about meeting their need in those conversations, not just with social workers at an assessment and care management stage, but also at a front door stage. So actually, how do we work collectively to kind of understand the need, meet the need, and then how do we demonstrate that we've kind of listened, taken that on board, and then reacted to that? We're also doing some work about kind of streamlining the decision making to get a point where we can help and support. So we all know that financial assessments is a part of the social care process because it's a mean tested service. So it's about streamlining that process as effectively as possible to make sure that there's timeliness in our decision making. So that's another one that we're doing. The delivery of technology. So you'll know that we're currently out just reviewing a sort of a strategic partner with delivery of technology. So people should start to see more technology over the next 12 months come into some of the practicalities of meeting need. So where we can utilise tech to be less restrictive. And also, I think Councillor Clegg mentioned it earlier in terms of that extra care provision and that accommodation provision. We're doing a lot of work around an accommodation strategy and what is our accommodation need for the future. We've just got into a position where we've last week highlighted that the Hoplands Extra Care Scheme will be going ahead with North Kesteven and Homes England. Again, a massively important step forward for us as a county in supporting people to live independently, because we've seen now with the schemes at Welton and the schemes at Market Raisin, all of which are now full of people within those accommodations, has changed their lifestyles. So they're just some of the real practical things that we're doing that people should start to see a difference of. And that's and there's lots of other things on. So I'm very happy to have a meeting outside of this to kind of run through some more of the more nuanced elements that we're doing rather than the broader strategic stuff.
Thank you very much. Councillor Overton.
Sorry, just clarification. You said strength-based conversation. What's that? Thank you.
So I'm more than happy to take that. So I think at its heart, strength-based practice is about hope. When we work with people, it's supporting people to see what's possible in their lives, and it's about building on their strengths and those around them and connecting them and helping them to achieve a life they want to lead. So rather than sort of us just thinking about putting a package of care in place, it should be about what's the person trying to achieve, what are their goals, what does a good life look like for them. And people should leave those conversations feeling listened to, understanding what they can do. They should know about what support is available around them, but what positive steps can be taken next. So it's about helping people to see opportunities rather than taking control over their lives and rather than just assessing eligibility for services.
Thank you very much.
Thank you.
Councillor Cook. Oh, is he? Oh, sorry. Yeah. Go on then.
Waving at you all.
Sorry,
Hi.
Councillor Cook.
Yeah, thank you, Councillor Woolley. Yeah, I mean, knowing what we know now, and it was an appropriate suggestion, we should really be writing to the DHSC about the long, frustrating way. We're all frustrated. And I've got to pay praise to Martin and his team for the way they've conducted themselves throughout all of this. All I can really say. So I think we've got to let where we are now play out. I suppose it's a case of knowing where we are. If we knew where we were, how's the saying go, now, so earlier, we may well have done exactly what you suggest, but we are where we are now. All I can say is regards to, as Martin put on some slides, the Adults Improvement Programme. I know it's been running for 18 months, but certainly from when we took over control of this administration, we really stepped it up a gear. So irrespective of, and I take your point about alerting or complaining to the relevant authority, the DHSC, about the way we've effectively been treated through this process. All I can say is what we're just carrying on. We're carrying on trying to deliver the improvements that are necessary for adult care in this county. I think that's what our residents would expect.
Thank you very much. Councillor Cook.
Thank you, Chairman. Thank you, Councillor Clay, for that answer. I still think there's a value in writing to the DHSE, and I think actually to keep them updated in terms of where we are, and also on a ministerial level, because I think at some point, you know, our MPs need to get involved in this, because it's not appropriate that the CQC have dragged it on for so long. And I think just on the CQC, and obviously we don't have the result that we have here, so I'm not going to speculate as to what that may or may not be. But obviously we've had a draft report into the council, and obviously that highlights certain areas of either improvement or fantastic areas. And I guess my focus would be on the areas that may seem to focus on areas of improvement that are required. Are we already working behind the scenes in ensuring that we are working on those, and can you provide assurance to us as a committee that any areas that were identified in the draft report, whether we agree with that report or not, there is currently a bit of a work plan behind the scenes in terms of addressing those areas, just to give us assurance. And I think obviously when the CQC report does land, can you confirm that there is a communications plan already in train in terms of how we communicate those results to service users, to members of staff, to councillors? Because obviously whatever the result it will be, obviously we need to be very on the front step in terms of communicating what that result is, where there are areas of improvement, but also celebrating the areas of where we have done really well, and also to provide that assurance to our staff predominantly as well in terms of their work, because we know how committed they are, and we've heard that from across this chamber today. Thank you.
Thank you, Councillor Cook. So a couple of questions really there. So the first about have we already been building this into the Adults Improvement Programme? Yes. Absolutely. It's one of Martin's key tasks, which has been being taken forward. So right from when we had the initial partial feedback when they'd finished their site visit, you know, right from that point we've been listening to what they've said, and we've been reflecting on that and making sure that the Adults Improvement Programme does pick that up. And that's therefore part of the frustration that this has all taken so long, because in a sense we're already, you know, the report is already out of date because we've already been working forward, partly in response to what was said. In terms of the communications, yes, we have a plan. I have a meeting penciled in the diary for all of my staff, a Teams meeting to brief them on the findings and our response. We have draft letters already prepared for members, for partners. We have draft media releases. It's all there, and I was going to say ready to go. We'll need to review it in the light of what finally gets said. But yes, we have everything in hand and in place.
Thank you very much. Like everybody else, I'm frustrated. By the time we get the report, we'll be doing another inspection. So, yeah, it's well out of date. Thank you ever so much for all your comments and questions. This now concludes the discussion on this item. I move that the committee has considered the report, bless you, and received and noted the updates by the Executive Director for Adult Care. I further ask that the CQC's report, once published, be shared with members of the committee for information, that a more in-depth review of the report be scheduled by the Health Scrutiny Officer into the committee's work programme. Please raise your hands if you agree. Thank you very much. That is agreed. Agenda item 7, Scrutiny Committee Performance Framework 26-27. This pre-decision scrutiny report can be found on pages 33 to 42 of the agenda pack. A decision will be taken by the Executive Councillor for Adult Care and Public Health between the 4th and the 10th of August. This report will be introduced by Martin Samuels, Executive Director for Adult Care. Martin, over to you.
Thank you, and I'm going to reassure the committee that I'm not presenting all of the reports, so it won't
lovely.
won't just be me. Won't just be me. And thank you for permission to take my jacket off. It is quite warm in here. This is about the new performance framework for the year that we're in now. Members of the committee will be aware that the executive and through them full council have adopted a new council plan which has set out new ambitions and new aspirations for the council as a whole. As part of that, there's been development of a performance framework to support that plan, and it also makes sense, therefore, for us to review the performance frameworks that we use to report to each of the scrutiny committees, and therefore, obviously, looking at the element of that for this committee. So we've taken the opportunity to look really quite hard at the range of indicators that we report to this committee, and we've gone through as officers through a process to identify what we think would be a appropriate suite of indicators to recommend to Councillor Clegg, and this is therefore an opportunity for this committee to make comments to be considered by Councillor Clegg when he looks at this. I think it's worth noting to say we collect an enormous amount of data in relation to adult social care and public health, an absolutely vast amount of data. We are required to report on a very wide range of indicators to the Department of Health and Social Care, and we also are involved in both regional and national benchmarking exercises with a very wide range of indicators. And therefore, it's a question of, from this huge range of indicators and data, what is it that would be useful for the committee, and particularly trying to get that balance of giving the committee a perspective over the full breadth of what we do, picking up Councillor Overton's point about what impact does this make for real people, because we can have lots of numbers, but actually the important thing is the interactions between individual members of staff and individual members of the public, and the quality of life that individual members of the public have. So how do we get the range of what we do compared to that focus on individuals, and just to give a sort of sense of the scale of what we do. I was again through the LGR work. I was just recently looking at the work of the districts, and not intending this to come across wrong, but I looked at the budgets of the districts, and if you exclude the housing revenue account from that, the budgets of all 7 districts put together is about half what this council spends on adult social care alone. So I think it gives you just a sense of the scale. I mean, there's also about 10 times as many people work in the sector as work for all of the districts put together. So it's a huge area. So we're trying to get something which is focused on individuals, gives you a sense of the breadth of what we do. I'm also particularly focused on ensuring that all of the indicators that we present to this committee are things that we can look at both longitudinally in time for Lincolnshire, and that we can compare with the performance of other local authorities. Because knowing that in Lincolnshire we did this year and we did that last year, but we can't tell you any more than that, doesn't really tell you very much. But being able to say, well, over the last 5 years the trend has been this, and compared to our statistical neighbours we're that, I think that is much more important. So what we try to do is to give a set of indicators that will do that won't bury you in detail. We've therefore taken the opportunity to have a slightly smaller list of indicators because the number was disproportionate compared to other scrutiny committees. One point that I would like to note is I know previously there's been some concern that if we change indicators then there's a loss of continuity. All of the indicators that are put forward are things that we have been measuring for some years now, and therefore we have longitudinal data on all of those indicators. So we'll be able to, would all of them be able to say over the last several years, this is how we're going. So no loss of continuity whatsoever. So really this is an opportunity for the committee to consider these indicators and see if there are areas where you would like us to look again. If there are indicators that we could do, which are things that we already collect, it would be possible for those to be built into the Q2 reporting. Q1 is so near that we wouldn't be able to, we've got the data, but we wouldn't be able to change the reporting process, but we would be able to for Q2. If the committee asks for things which aren't currently being collected, that becomes a bit more difficult because we'd have to institute a new collection, and in the context of LGR, instituting a new collection that we might well only use for a year and a half because the two new unitary authorities might or might not carry on. I think we'd look at that, but very open to if the committee has areas that you think we've missed, then very happy to consider that. But again, not wanting to be in a position where we're not drowning you in the detail. Yeah. Thank you, Chair.
Thank you. Will Lucy Gavins from Public Health Consultant be presenting anything on this item? No.
I think only if the questions get into
only
public
if the questions.
health.
Okay, thank you very much. Thank you for the report, Martin. That's fantastic. I would now like to invite members of committee to comment on this item. Councillor Lee.
Thank you, Chair. And do indulge me. Martin, this is a genuine point and a genuine question. In recent months, we decided, this council, some people on this council decided that One U Lincolnshire wasn't a very good idea and we didn't need all of those wonderful preventative healthcare measures that they provided. I mean, the most significant was weight management, because an unhealthy weight impacts on so many different illnesses, be it diabetes or heart disease, lots of different ways. And I said at the time I was worried this would mean that there would be an increase in health because we wouldn't be preventing it earlier, and that people who were already ill and were being given help to manage it would die younger. And I really would ask that we start to measure that in some manner. I think that's essential, because that was a major policy decision for this council. You know, there's evidence of high levels of all of those diseases in Lincolnshire, and the last administration had funded that programme for, I think it was 6 years. So I would ask that we start to look at the impact of withdrawing preventative adult public health services, because I think that's vital. Thank you.
Can I come back on that? And I might ask Lucy to give a more detailed aspect from the public health side of things. So one of the things that we have been measuring and will continue to measure is I was going to say the weight of the population. That's not quite what I mean, but you know what I mean. And so that data is available and will be reported through public health routes. But we took the opportunity to take that out of the indicators because I note the comments you make about the integrated lifestyle service, and there is no question that service has had and continues to have, because it's still there, a significant impact on weight management for the people who go through that service. As a proportion of the population of Lincolnshire, it's a tiny proportion, and therefore the ILS activity, while without question hugely beneficial for the individuals that go through it, doesn't really have much impact on the average weight of the population, if you see what I mean. And so the sense was that we might take that out, but I'll turn to Lucy as a public health consultant who knows more about these things than I do.
Can I just ask a question? And as a member of this committee, can I ask that we put
through
that
the
back
chair,
in?
Councillor Lee.
Through the chair, then,
Yeah.
can I ask, please, that we put those performance indicators back in, because I think it's really important, and it was a measure of the health of people in Lincolnshire. We wouldn't have spent so much money on it over 6 years if it didn't matter.
Thank you. Lucy, do you want to come back?
Yeah, happy to just add that, just to reiterate what Martin said, really, that we do collect data on several different outcomes, so overweight, obesity, physical activity, physical inactivity, and that data is collected for all local authorities, so we're able to compare, to benchmark ourselves against other places. It's available in the public domain. So that data is already out there for people to review. So, but I would also say that the integrated lifestyle service is one of a constellation of factors that impacts on weight, and it is really important that as part of our overall approach to thinking about how we support people how we prevent people from developing overweight or obesity in the first place, that we do think really broadly about the different measures that we need as a whole system across Lincolnshire to support people to essentially to avoid or to lose weight if they are overweight or obese.
Through you, Chair, my point wasn't just about people being overweight, and this is scrutiny, so I hope you'll let me ask the question. I'm asking that this committee is given the information. What bothers me is that people will be dying younger, not just because they're overweight. I mean, coronary heart disease, it comes from other things. And what I'm asking you is, we've been asked if there's anything else we'd like in here. Well, I'd like to know if the people, for those preventative services that have been withdrawn, if we can please have the data, the data that's in the public domain, can we have it in the reports, please, so that we know if people are dying younger? Thank you.
Thank you very much, Councillor Lee. Is it possible to have a link onto our report where they can get the public data? Because I don't want the data to be fully in there and then we're not live, if you know what I mean. So, well, if it's not up to date, but yeah, Martin.
I'm happy for us to take that. I mean, I'm happy for us to take that away as a suggestion from the committee and to look at the possibilities.
Perfect. Thank you, Councillor Lee. Councillor Woolley.
Thank you, Chairman. Performance indicator number 31, which is about the alcohol and people having left specialist treatment. I'm just wondering whether it's stretched enough, because I think that means yes. Yes, it does just seem as though it was an easy number that was reached, and whether it should actually be a little bit more challenging. So, can you just give me the background as to why you decided not to stretch it?
Thanks, Councillor Woolley. So it was set essentially as an absolute minimum. One of the challenges that we face within the drug and alcohol treatment service, particularly around our alcohol users, is an increasing complexity of need. So I think it is a fair challenge, and perhaps something that we should have a look at. But it is based on sort of our national targets that are set. But we certainly could have a look at that locally and think about stretching it a little bit more. Yeah.
Thank you very much, Councillor Overton.
Thank you very much. I think what you're saying is that we're going from 199 targets down to 11. I think the ones on here, or these are just going to be the ones that are reported here. Yeah.
So if I can just clarify, the numbering system applies to the council as a whole. So the 199 or so is for the whole council, and then there's a selection. So I think when we looked at it, this committee was receiving about twice as many data points as any other committee, and therefore the suggestion was made that we align it more. So I think I have got. Let me just say, I've got a slide which tells me there are 1, 2, 3, 4, 5, 6. There are 6 targeted measures fewer, and there are 4 contextual measures fewer. And contextual measures, we don't set a target, we just report them. So it's reducing by just over a third the number of indicators. But the aim is to ensure that you have a sufficient focus rather than us putting so much. I mean, again, that issue of not making the haystack bigger to find the needle.
Thank you. You made the point at the beginning how much bigger adult care was than the other services, and indeed how many more staff are involved, and therefore I guess how many more public residents are directly engaged as well. So I'm not worried about a larger number of targets. If it was half as much again, that doesn't seem to me to be much of a problem. If we went from 11 till, well, even to 20, I don't think that's a big problem if they are helpful. And I think what I can see in the way you've written these is that many of them are written quite carefully so that they can be properly measured and tell us what we want rather than getting other bits of information that we didn't want. So I think they're well written. But I want to pick up the point, the other point is that you've got here, you've got about whether they've had an NHS health check, whether they quit smoking, whether they are get a check at home for care. So, you know, these are the things that are in public health that we normally look at, and alcohol, of course. So it's quite surprising not to include weight being such a significant one. And I think I wouldn't have a problem at all with including that as a target, if you like, something that we are focusing on working on, and comes to this committee and we can all think about how we can, you know, we can all contribute about how we can improve the state of affairs of Lincolnshire, if you like, in that area of health to do with weight. So I think, you know, that would be another one single more target, you know, not a problem for me. And I think it would help us focus on what's important for our residents. Thank you.
Thank you, Councillor Overton. Ultimately, it's Councillor Clegg's decision, so it will be captured in the comments. So anything's welcome. Thank you very much, Councillor Bean.
Thank you, Chair. Can I ask what arrangements are in place to ensure that the KPIs actually drive continuous improvement rather than just reporting for reporting's sake?
That's a very good question. Reporting for reporting's sake obviously doesn't achieve anything very much. So the factors that are there, so a couple of things. One is obviously on a quarterly basis, we will bring the report to this committee, and I think it's fair to say that the comments made by this committee have an inspiring impact on me and my team, and they do drive our activity. And I'm aware that I may have said that in a tone of voice that was a bit didn't quite come across right. Genuinely, you know, we are very conscious of what this committee says, and it makes a difference on what we do. We do run the process very rigorously within the directorate. So every month I have a meeting with my management team, and we go through the performance. And one of the really important things that we've changed over the last couple of years is that it used to be the tradition, and indeed you'll be familiar for this committee, it used to be the tradition for the performance team to present the performance, and effectively for the performance team to say this is the performance, and then the service to sort of reflect on that. And my experience was that didn't encourage ownership, that the performance team we would be bereft without them because they understand the numbers in a way that and can manage the numbers in a way that the rest of us can't. But it is me and my team that deliver the numbers. We're the ones that make the difference, that, you know, that have the responsibility for the services. And so what we've been doing now in my performance meetings every month is each of my heads of service in turn goes through about what's happening in their area, and they need to show that they understand what the performance is in their area, they understand why things are going in the way they are, that they have, where there are areas that require improvement, that they have actions in place to do something about it, and I hold them to account. And then of course I then have conversations with Councillor Clegg, and he holds me to account, and of course this committee holds me to account. So I think there is a robust process. This isn't just sharing numbers, this does drive performance.
Yep, Councillor Bean.
If I can just come back on that, I'm reassured that we're not just going to end up changing policy to make KPIs look good, and we're actually going to use policy change to drive better services. Thank you.
Thank you, Councillor Bean. Councillor Hume.
This is just a suggestion in terms of what data, the KPI data. I noted number of alcohol users leaving specialist treatment, and the same for smoking cessation. Do you collect follow-up data, say a year later? And wouldn't it be interesting for us to be able to see the longer-term effectiveness of that?
Yes, absolutely. So they're collected different ways in the different services. So for smoking, we do follow up, but over quite a short term. For alcohol treatment, it's a much longer term follow up, and it's national, so we can understand from within our own service users if somebody has left treatment in Lincolnshire, but for example they turn up in treatment in Devon, that gets tracked. So for alcohol, we have something called the National Treatment Data Monitoring System, which collects all that data nationally. So we do follow up, and we also look at other outcomes. One of the challenges with this kind of with feeding that data into this kind of reporting is that it's got quite a big lag in terms of how long it takes. But one of the things that we do, and I believe it's on the agenda for scrutiny at the start of next year, is for me to bring a paper on the performance of the substance, or not the performance, but how the substance use service is working, and to be able to talk through some of the outcomes that's delivering. So that would probably be kind of a good point at which to talk through some of those things. Thank you, Chair.
That's great. Martin, do you want to just jump in?
Yeah, just sort of following up on that and just reflecting a bit on some of the comments that have been made, which I think are really helpful comments. In addition, of course, to the quarterly reporting that we do try to have a cycle during the course of the year where we bring reports to this committee about particular services. And I think there may be a possibility for some of those services where, even if there isn't an indicator for them in the indicator set that we bring every quarter, that we could certainly bring a report on that particular service. So for example, I mean, Lucy's just been talking about the smoking cessation service. We'll be coming in due course on the recommissioning of that service. It would be entirely possible for us to bring a report about smoking cessation and related activity, and to give the committee the opportunity to have an in-depth conversation about that. And we would be able to bring a whole range of data, much broader than just the specific things that we would have in the normal suite. So we can effectively complement or supplement the standard quarterly data set by having deep dives on particular issues in whatever way the committee would find helpful.
Thank you very much, Martin. Councillor Bean.
Thank you, Chair. So I'm aware that we're currently reviewing Lincolnshire County Council's Section 17 crime and disorder policy. I'm just wondering, moving forward, how this policy is going to affect the future delivery plans for adult care and public health.
Yeah, so both adult care and public health are involved in the working group and part of the plan. So there'll be detailed plans within that were scrutinised at the scrutiny. So I'm very happy to share with members here the impacts of that Section 17 crime and disorder strategy and the plan that then would outline what the activity is.
Thank you very much. Thank you for your questions and comments. Oh, Councillor Overton.
Just a thought. The other part was access to mental health care services and care. I don't know if that's. I think it might be covered by what you said, but should that? I think we used to have that as something in there as one of our targets for us to focus on. Thank you.
And again, we can look at that now that the working age adult mental health adult social care service has been brought back into the council. The data on that is essentially included within our working age adult social care data. And of course, the NHS will report on data in terms of access to mental health services. So we can subdivide by primary need, but essentially that data is included within the wider working age adult data. So again, it would be the sort of thing where we could bring a report, and as I would suspect that the committee would want to have a report about the working age adult mental health adult social care service in a few months' time, reporting on how that transfer from LPFT back into the council has gone. But the activity data would be included within the working age, the broader working age adult activity. But we do collect it, so we could then disaggregate it for a deep dive report on mental health as a sort of in the autumn, early next year. That sort of timing, if the committee would find that helpful.
Yes, thank you.
Thank you very much. Thank you, Martin. Thank you, councillors. Thank you for your questions and comments. This now concludes the discussion on this item. The committee's comments will be captured by the Health Scrutiny Officer and will be passed to the decision maker ahead of the decision being made. I move that the committee will be considered for scrutinised, that we scrutinise the report and that the recommendations to the Executive Councillor. Please raise your hand if you agree. Councillor Lee.
Can I ask for a comment on there, please, that we did ask for weight management to be included? Because
Yeah,
I think
they're
it's
already
very
captured.
pertinent.
Everything's already been captured, Councillor Lee. Sorry, please raise your hands if you agree. Obviously, with all the comments involved, yeah. Thank you very much. Yeah, that is agreed.
Chair, can I abstain, please?
Yes, you can. Any more abstentions, anybody? No, just Councillor Lee. Thank you. That is agreed. Thank you very much. We'll now take a 15-minute comfort break, and we're back about 22. Thank you. Agenda item 8, service level performance reporting against the performance framework 25 to 26 quarter 4. This quarterly scrutiny report can be found on pages 43 to 68 of the agenda pack. The committee is invited to consider and comment on the report. This report will be introduced by Martin Samuels, Executive Director of Adult Care. Martin, over to you.
Thank you, Chair. So this will be the last quarterly report that will be provided to the committee on the basis of the previous set of indicators, and obviously the last item that we discussed was about the future set. So overall, I think it gives a pretty good picture, and it's worth noting that in a number of areas and for most of these indicators we can compare ourselves nationally or with the rest of the region. In most areas we do at least as well as the average, and in many areas we do significantly better than the average. I'm not going to go into significant detail. However, I'll just pick up three of the indicators. So you'll note there are three measures that didn't meet the target. I mean, in some ways, I'd like to sort of celebrate some of the areas where we exceeded the target. And actually, having said that, I'll particularly flag that we were very successful in the proportion of adults. So this is indicator 158. The proportion of adults discharged from hospital who remained at home 91 days after discharge, and that's a really important measure of how safe that discharge was and how well that's been handled by adult social care to make sure that someone was indeed fit for discharge and they received the support that they needed at the point of discharge, because it can very easily get into an issue of people flipping to and fro between home and hospital, which tends to be incredibly unsettling and bad for their health outcomes, and also very expensive to the system. So we're in a position where at quarter 4, 90.4% of people who were discharged from hospital were still at home 91 days later, and that is a really good performance, and compares extremely well with performance elsewhere in the region and the country. But picking up the three indicators where we didn't meet the target. The first is indicator 60, permanent admissions to residential and nursing care homes for people over the age of 65. So we had a target of 950, and we actually had 1,046, and this is one of those indicators where smaller is better. As a residential and nursing homes do incredible work, but you only want to be there if you really need to be there. So worth noting that we were perhaps a bit optimistic with that target. Members of the committee will be aware that Lincolnshire has one of the oldest populations in the country, and it's ageing rapidly, and therefore we were perhaps a bit optimistic there, though we should be setting stretching targets. I would note, and we covered this briefly in the earlier item, Lincolnshire is slightly below the national average in terms of the number of people over the age of 65 who are entered into residential or nursing care, and our rate of increase does seem to be a little bit less than other authorities. And we have, if you compare the figures, the indicators for this indicator set and the proposed new set, we are suggesting a switch from an absolute number to a rate per 100,000, and that will make it easier for us to compare with other authorities. We will of course still have the absolute number, and that will be available, but the switch to the rate will make it much easier to make that comparison. The second indicator where we didn't meet the target is indicator 65, people in receipt of long-term support who have been reviewed. And I think it's worth giving a bit of context to that. So that figure, the target figure of 85, that's a percentage figure, 85%, that was pretty much where we had been for a couple of years. That is one of the highest figures in the country. Even with the reduced performance of the Q4 figure of 68.6%, we are still well above the national average. I would like to be clear that that change in performance is a result of deliberate policy. So it's not a failing by the team, it's a deliberate policy. And the basis for that is with the increase in demand, I'm not getting an increase in the number of social workers. I have to use the social workers I've got in the most effective way, dealing with additional demand. And I, in consultation with my senior staff and with my principal social worker, took the view that it is more important to ensure that we are timely for people requiring a first assessment who are coming into the care system, who therefore are not receiving care but need it. It is more important for us to be timely with those individuals than it is for us to review people who are already in the care system and are receiving care. And in particular, I'm a bit more relaxed about a little bit of delay for people who are already in the care system, because with them being in the care system, they are being seen every day by a carer, and we have arrangements that if the carer or indeed the family believe that there has been a change in someone's need, they can ask for a review there and then of the individual's needs, and we do that. We'll do it. You know, we'll then do the review, that helps us to make better use of the social worker time. Something like 2/3 or 3/4 of standard annual reviews lead to no change in the care package. So it's a useful thing to do, and I'm obviously clear that we will continue to do annual reviews, but the vast majority of them lead to nothing, no change at all, and I'm therefore trying to focus the resource I've got on people where we know there's been a change, either because they've come to us for the first time for an assessment, or because their carers or their family have said there's been a change and they need an assessment. So I'm focusing on where it's going to make a difference. I know every single review where there's an urgent review of an existing package, every single review where there's a new assessment will lead to something, whereas the vast majority of reviews that are just time served, as it were, lead to no change. So that's a deliberate policy. And then the third one, where we haven't hit the target, and it's on the public health page, so it is indicator 111, people supported to successfully quit smoking, where we didn't hit the 4-week quit target. The reason for that was that DHSC gave us some additional funding last year, and one of the conditions of us receiving that funding was that we double the number of smoking quits that we achieved. The funding that we received additional wasn't sufficient to allow us to double the number of quits. So it wasn't that we set the target, it was a condition from DHSC that we set the target. Interestingly, there's no sanction from not hitting the target, but it was a requirement for that. And again, if you look at the indicator set that we've proposed for 26, 27 that we discussed on the previous item, we've revised the target so that it will be a stretching but achievable target within the resources that are available. So I'll stop there, Chair.
Thank you, Martin. I would now like to invite members to comment on this item. Councillor Cullen. Councillor Reeve.
Thank you. Thank you again, Martin, for your work. I think it's very valid what you're doing. I have a strange thing about smoking. I think it should be up to the individual whether they want to smoke or not. However, I am totally in favour of working towards helping them stop if they choose to stop. But I do have a slight problem with page 66, the last paragraph, about smoking in pregnancy, where the women there are referred to pregnant people and not pregnant women. And then they do emphasise the fact later on by saying parents of the pregnant lady, but at several points in the paragraph it's pregnant person. And unless I miss something in biology, only women can be pregnant. So if there is another report next year that goes deeper into smoking cessation and drug use targets and how long it's monitored, that sort of thing, can we please not have women referred to as pregnant people? I don't think it's the right way forward. Thank you.
Martin, thank you.
if I can just pick up the issue about whether people want to smoke or not, emphasise all of the people we work with in the smoking cessation service are people who have come to us because they want to stop smoking. So we don't go out on the streets and drag people in and leap on smokers. All of them, you only come into the service because you've said, I want to stop smoking and I can't, because of course we know that nicotine is a highly addictive drug. So give you the reassurance that is, we will certainly want to encourage people not to smoke, but the smoking cessation service is entirely people who have said they want to smoke, they want to stop smoking, but have been unable to do so on their own basis.
Thank you very much. Councillor Hume.
Just to ask for a little bit of clarity in terms of, for example, performance indicator 124, there's only a 0.3 difference there. I just wondered, what is the significance of that 0.3 difference?
Oh, right. So we've achieved 99.6%,
right,
and yes. So in terms of numbers, I mean that's literally a handful of people.
Right. So it seems to me that perhaps you're being a little too harsh on yourself there.
I'll have a word with my performance lead who sat behind me.
Okay.
Thank you very much. Councillor Lee.
Thanks, Chair. Just thank you for your work on this. I'm really pleased to see the data around reablement and the wellbeing service, because the point that you made earlier, or one of your colleagues made, about it being about helping people be the best that they can be and what they want to achieve, it all fits in with that, doesn't it? It's really good. I would just say as well, I honestly think we've got bigger things to think about, and about if it's women or people. If you really want to split hairs, it takes 2 people to have a baby, and a lot of couples say, we are pregnant, but I honestly think at LCC we've got bigger things to think about. Thank you.
Thank you very much. Councillor Carey.
Thank you, Chair. Yes, regarding your smoking quit targets that have not been achieved, which demographic or geographic areas are showing the weakest outcomes? Thank you.
So what we tend to see is that smoking rates are highest amongst our people living in our more deprived areas. So without naming specific places, we will see concentrations of, we're more likely to see people who are smoking in places like in Lincoln, down the coast, in Gainsborough. We do have people smoking across the whole population, but we tend to see that it's people in those communities who are more likely to smoke. And there's lots of different reasons for that. It's also much harder to quit potentially for those populations, because one of the things that many people will know about smoking is it can be quite a social activity, and if lots of your friends and family smoke as well, then it becomes a more normalized behavior, and it can be really difficult to quit something as addictive as nicotine if you're surrounded by people who are smoking. But they're the kinds of the places where we tend to see more people smoking.
Thank you very much. Councillor Cook.
Apologies, I had to take a call then, Jack. Just on the smoking, because everybody keeps mentioning it, and obviously I think one of the things that, and this is a little bit off topic, so just bear with me a second, so the nicotine pouches have massively risen over the last couple of years, and actually the level of nicotine in those is far higher than what's actually in cigarettes in many cases, and is at some point, will we have to review that as a council? Because as people do move away from smoking, and you do notice it socially, like less people smoke, but a lot more people are using these pouches, and I don't know how safe they are in the community or not, but actually you can see a huge increase in usage. And actually I think one of the things we should be looking at is, because you do see younger people using them out and about, and I think actually it's probably an area that we probably need to look at in the future. That's just the first point, if that's right, Jan. I've got a proper question.
It's a really good point. Nicotine comes in lots of different formats, and smoking is only one of them. I know from I guess because behaviours change in different parts of the world, or for example in Scandinavia, kind of chewing tobacco and things like that have been very common for a while. What we do tend to see there is, for example, higher rates of oral cancer. So whereas smoking tobacco has an impact on lots of parts of the body, but particularly can affect kind of the lungs, the esophagus, the mouth. If you're chewing it, then it tends to affect the lungs less, but we see higher rates of mouth cancer. So you're absolutely right that it's really important that we keep an eye on all the different ways in which nicotine is being used, to keep ahead of kind of what impact that's having on the health of our population, and where appropriate that we have support available or can signpost people to support to quit nicotine as a whole, not just smoking.
I don't think we've moved on too quickly on the agenda, so we are still on item 8, aren't we, Chair? We are, thank you. So reading the report, so the proportion of people receiving an annual review has fallen to 68.6% is what I've read in the report. So how are we prioritising reviews according to risk? And I suppose what assurance would you give us as a committee to ensure that people with sort of changing or complex needs are not being left without that sort of timely assessment?
So I think I may have covered a bit of this while you were out of the room. So the key thing with people who are in service is that they are in the service. They are being seen every day. So we have a risk-based approach of understanding people's needs and making sure that we get to people on that risk basis, but also because they're in service, they're being seen every day by carers, and therefore there's the opportunity, if those carers identify a change in someone's level of need, that they can flag that, and that will then do that as an urgent review. So if someone needs a review, then we can we can pick that up, and then of course we do review, but we do look at the entire population of people who are waiting, so that we can make sure that people don't wait too long. So we can the NHS term that we used to use when I worked there, slightly inelegant, was tail gunning. You keep an eye on the people at the end of the queue, and you make sure that people don't get too long, that you do pick them up. So we have those risk-based processes. We make sure we get people at the end of the who are at the end of the queue, as it were, and we have eyes on them. I mean, Lincolnshire is one of the areas nationally that has been leading in having provider-led reviews, where providers, who are the people who know the individual better than anyone else because they see them every day, and they will do an assessment themselves on a regular basis, which is part of their CQC requirement. We have arrangements where providers can do that on our behalf, and we do appropriate checks to ensure quality. But again, that's a way that we're looking to expand, so that we do pick up those reviews, and people be confident that if there is a change in their need, that it will get picked up in a timely manner.
Thank you very much. Councillor Young?
Well, on a similar question, Chairman, really, in terms of long-term support. Martin, I listened to in terms of what you said in terms of the services approach to reviewing. It does seem low to me in terms of the 68%, in terms of they are the most complex, vulnerable people, aren't they, in terms of long-term support. I would imagine in terms of cost as well and finance, they're the highest care packages in terms of support. And I just wondered, in terms of actually, is there a trigger point where it goes beyond the 12-month period? When does that kick in? I would imagine that there's lots of individuals placed out of county, and there's also lots of individuals placed in county. Is there arrangement around with neighbouring authorities in terms of how those review packages are reviewed? Yeah, I'd just be interested in terms of more assurance around the trigger mark, in terms of actually that nobody actually is falling through the net, and they go well beyond the 12-month period and it extends to 2 years.
So I've forgotten what the exact figure was. The 68.8%, whatever, 68.6%. That's still well above the national average. So most authorities across the country do a lower rate than Lincolnshire does, even at that 68%. We very much have a risk-based approach. So you made the point about people who are placed out of county. There are some arrangements with some authorities for them to review people, Lincolnshire people who are based with them, and we may have arrangements to review their people who are based with us. Because there's 153 authorities in the country, there's no national system, so the assumption is that you do your own, and that does also mean that there's a greater likelihood of knowing who the individuals are, having that continuity. And then we have a risk-based approach that people out of county are more likely to be reviewed because they're less in sight, as it were, than people who are in county. But I think that fundamental principle that people who are in the care system are being seen every day by a carer, and so therefore their level of risk is much lower than someone who's not yet in the care system but is seeking care. And so therefore it felt from a risk basis more appropriate to shift the capacity I've got onto the new assessments, but while keeping an eye out. So we're not forgetting people. Everyone will get picked up.
Thank you very much. Councillor Bean.
Thank you, Chair. Are there any performance challenges linked to resource constraints? And if there are, what options exist to mitigate them?
I'm tempted to say, how long have you got? So resource issues. So I could always do with more social workers. I don't think the council has the money for me to employ significantly more council workers, more social workers. There aren't that many. Actually, there's a national shortage of social workers. If I had more social workers, there's more that I could do. But a key part of it is a rushed social worker is an expensive social worker. It's always easier if you're rushed to give someone a bigger care package than to take the time to work through, as Chris was saying earlier, in his role as principal social worker. That strength-based conversation takes time, and therefore it's harder for us to do that within the staffing resource that we have. We also have the issue that sometimes finding care packages can be a challenge. The adult social care workforce, the external adult social care workforce, is largely a national living wage workforce. That has been a national trend over the last 20 or 30 years, as those services that used to be delivered by councils have been outsourced, and has been the way that we've kept within budget. But a national living wage workforce is a challenge. It means that any job they go to will pay at least as well. The career prospects within adult social care are often very limited. We find that staff with 5 or 6 years experience get paid 50p an hour more than a new starter, because the fee rates are based on national living wage. So there can be real issues in terms of the rate of turnover, and sometimes the level of training and experience of staff out there. If I was able to pay a bit more, then we might be able to deal with that a bit. The government has put in place a fair pay agreement, which will kick in from April 2028, and they've made some funding available, so that we may have some options there. We find it quite challenging to find the right placements for working age adults, particularly with learning disability. There's the economics of the market means that there's never quite enough provision of the right sort, which is very much the same model that has been found in the children's world, the children's residential world. The economics there again mean that there's always not quite enough provision. I could go on, but these are all things which are not unique to Lincolnshire by any means, and are things that we're working on. Particular aspect of things that we're doing, really some of the things that Martin was talking about earlier. So the strength-based approach, where we focus on prevention, where we get to people at an earlier stage so they don't develop the need, that tends to represent very good value for money. The use of tech, so that instead of someone having to have carers coming in, then people if instead of people coming in using tech, that's often not only very good for their independence, but actually, again, saves money. Streamlining the processes for assessment and financial assessment can save staff time so that we can use that in the most effective. And again, I could give quite a lengthy response, and I'm sure that my team could all come in, but I think that gives you a flavour of it, Councillor Bean.
Thank you very much. Martin, do you want to come in quickly?
Yeah, I'm just going to come in very quickly. So main thing is are we going to get more additional resources now? How do we make them more effective and more efficient? Technology is one of those. So we're looking at, we have demand failure where we have a system where we're calling people to have a conversation, but yet we have a really robust and strong booking system that our registration services use. Well, why can't we get people to book on to having that initial conversation to assess need? Then there's no failure. So one, they're picking the time that they do it when it's convenient for them, and they're expecting to have that call. So that becomes far more efficient. We're looking at our talk to text tools. So effectively for the council called Sonic Brief. So that will aid, the adult social care process is really bureaucratic. So actually how we're using AI tools to assist us in having a strength-based conversation and having tools capture that. So we're not thinking about looking at a screen writing, we're actually having a proper engagement with the individuals, and also looking at our structures. So, social workers are experienced in meeting needs, having conversation with people. Are they experts in care sourcing and finding the right approach? So we're looking at our resourcing, and we're looking, if part of our new commissioning type model is how do we utilise the skill bases in the best way? So it's not about more people, it's about being more efficient, more effective with what they do and how they do it, as well as a target operating model that is trying to kind of make the communities more resilient and how we support that.
Thank you very much, Councillor Lee. Oh, lovely. Thank you for your questions and comments. That now concludes the discussion on this item. I move that the committee has considered the report and has received and noted the updates by the Executive Director for Adult Care on the Q4 performance. Can you please raise your hand if you agree? Thank you very much. That is agreed. Thank you very much. Agenda item 9. Public Health Substance Use Grant Funding. This pre-decision scrutiny report can be found on pages 69 to 86 of the agenda pack. A decision will be taken by Executive Councillor for Adult Care and Public Health between the 29th of July and the 7th of August. This report will be introduced by Lucy Graves, Public Health Consultant. Thank you, Lucy.
Thank you, Chairman. So the Council commissions specialist drug and alcohol treatment services for residents across the county, and since the 1st of April 2024, these services have been delivered by the Lincolnshire Recovery Partnership, which is a partnership between Turning Point, Framework and Double Impact. Historically, our funding for substance use services has been made up of a core public health grant allocation, and then that's been supplemented by several separate national grant funding streams that have varied in value from year to year. At one point, we were managing 6 such streams simultaneously alongside our core public health grant allocation. From this financial year, so from 26-27, all of those funding streams have been consolidated into a single protected substance use allocation within the ring-fence public health grant. And Lincolnshire's allocation for 26-27 is 10.4 million, or just short of 10.4 million. That protection comes with some stipulations. For example, the funding can only be used for evidence-based drug and alcohol prevention, for treatment and for recovery activity. And anything we don't spend within a given financial year then has to be ring-fenced in a separate reserve for use in a future year on substance use prevention, treatment, recovery. Within that overall 10.4 million, there are some things we've also been told we have to spend money on. So we've got, and you'll see it in table 2 within the report, there are 3 areas where we've been directed to spend a minimum amount on certain areas. One of those is people who are rough sleeping or at risk of rough sleeping. One of those is people who are kind of in receipt of housing support or perhaps have kind of a vulnerable housing situation. And the third is individual placement and support, which is about supporting people in drug and alcohol treatment into work and helping them to sustain that employment. The rest of the money, within a menu of interventions, we can flex how we spend that to support or to deliver treatment, substance use treatment and recovery according to local need and evidence of what works. So The 10.4 million is made up of our core contract, which is 5.92 million in 26-27. And that's an ongoing contract with Lincolnshire Recovery Partnership. And then several other smaller allocations. For example, there's part of the funding is used to fund some LCC staff who commission the services and kind of do the contract management. Once those existing commitments are considered, we've got £3.62 million remaining, which we need to commit from that protected allocation of 10.4 million for this financial year for 26-27, and that's what the report focuses on. So it looks at how we're proposing to commit that 3.62 million through variation to 2 existing contracts. The bulk of that would go to Lincolnshire Recovery Partnership as our main treatment provider, so 3.24 million, and the other portion, just shy of 386,000, we're proposing would go to the Housing Related Support Service to enhance the work that they already do with people who are in receipt of drug and alcohol treatment services. The reason we're suggesting using the contract variations is it enables us to deploy the funding as quickly as possible, bearing in mind that how we spend the funding has only very recently been approved by national government, and we use our existing delivery agreements, which we're sort of into the 3rd year now of that new contract, certainly with Lincolnshire Recovery Partnership. When we commissioned the current service back in 2023, the potential for annual changes in grant funding was recognised. So we knew that this variation from year to year would come back in 2023-24 when we recommissioned the service. And so the contract was designed to support changes in funding over the lifetime of the contract. For the housing related support contract, this proposed investment aligns with the contract's existing objectives to support people with substance use and housing related needs. So in terms of what we're proposing that the additional funding would be spent on, within Lincolnshire Recovery Partnership, it increases treatment capacity, it strengthens support for children and young people, it expands our ability to do outreach into communities or individuals who it's harder to bring into services in set locations. It also supports people into employment through the individual placement and support offer, and it offers enhanced support for people who are already rough sleeping or who are at risk of rough sleeping or of homelessness. Alongside that, probation are also giving us an additional 214,000 because they would like us to be able to deliver specialist substance use treatment within their probation service. So that's for the 3.24 million for Lincolnshire Recovery Partnership. For the additional investment in housing-related support, this essentially provides enhanced support for people with substance use needs. It provides targeted substance use interventions within the existing pathways that they're already in to support them around housing, but it can also provide practical assistance. And particularly important is helping people to sustain accommodation. Once somebody with drug or alcohol problem has lost their accommodation, it can be really difficult to rehouse them. But if someone's got accommodation, then helping them to maintain that tenancy is really important to do to support their drug and alcohol recovery. We know this approach works because it's essentially a continuation with some small changes to what we've done over the last couple of years. So we've had this supplemental grant funding in previous years. It's contributed to an expansion of the number of people that we have in treatment. So we now have more than 3,500 adults and 220 young people in structured treatment across the county. It's particularly valuable, I think, for supporting people with complex needs into formal treatment. Because we can provide that enhanced one-to-one support, meet them where they are through our outreach. And we've got more specialists within the service who are able to support people, for example, who do have complex mental health needs alongside their drug and alcohol use, perhaps people who are in contact with the justice system. So it enables us to provide a much more enhanced service to that cohort who we know are even more likely than others perhaps to kind of return to treatment again and again before they get to their point of recovery. In terms of how the service is performing, it's broadly in line with national and regional benchmarks. So I mentioned earlier on in the meeting that we have something called the National Treatment Data Monitoring System. That's how we can compare ourselves to other parts of the country. And it's a really useful system for understanding where we're doing well and where we've got areas for improvement. We perform particularly well in retaining people in treatment, which again is a big priority for substance use. Most people will go through treatment 6 or 7 times before they reach that point of successful recovery. But we do have scope to improve support, I think, particularly for people who are what we would call alcohol-only clients, and for people who are using non-opiate drugs, so things like cocaine, and recently we've seen a big increase in ketamine users locally. And there's also a few case studies. I think there's 3 case studies included in the report, which are there to sort of demonstrate some of the impact and bring to life some of the support that people receive through the service. So they show individuals kind of reducing their dependence on opiates, people with kind of co-occurring dementia and alcohol problems, and also there's a case study from an experience of a homeless person. So just in conclusion, the funding represents a significant opportunity to improve outcomes for Lincolnshire residents affected by drug and alcohol problems, continuing some of the good work that we've been doing in recent years. The recommendations build on our already established and effective treatment service. It supports local and national priorities, and hopefully should provide a quick and effective way to maximise the benefits of the funding available for our communities. Thank you.
Thank you very much, Lucy. I would now like to invite members of the committee to ask any questions on this item. Councillor Reeve.
Thank you, Lucy, for that report. How is the public health grant being distributed between prevention, treatment and recovery? Because they're all quite different in themselves. And what changes have been made compared to last year? Thank you.
So the majority of the funding that I'm talking about here actually goes on treatment and prevention, because that's the expensive element, treatment and recovery, because that's the nature of our treatment service. That's where we need to invest the most money, essentially. So it's on things like key workers who will support someone through their recovery journey, through counselling and group work. There are medication costs associated with the treatment as well, which are a bit of a fixed cost, really. They cost what they cost, and that's not flexible. Prevention is a relatively small part of the funding pot, but in part that's because it's about prevention work is about supporting everybody across Lincolnshire, across the NHS, so kind of primary care and hospitals, working with people across the community and voluntary system, working with schools and other groups that are working with young people to embed prevention everywhere. We do have some specific posts that focus on prevention. So, for example, we fund workers within the Stay Safe programme, and they go out to schools, and we reach over 10,000 young people each year around to talk about alcohol and drug prevention. But it is the majority of the money is spent on treatment and recovery.
Thank you very much. Councillor Hume.
Just a very quick one. It might be useful, certainly for me as someone who's still learning, to see these data also represented sort of by percentage of population, sort of the first paragraph, in future reporting, just to put things into perspective, if that would be all right.
Yes, absolutely. More than happy to do that. The other thing, I'm conscious the paper was quite long anyway, and we didn't want to kind of make it too long. But I think the other thing that's probably important maybe to reflect in the future is what proportion of we could talk about it in terms of the proportion of the population, but we do also have estimates of need, which we can build in as well. So we can certainly think about building that kind of additional context, if you like, into the start of subsequent papers.
Thank you very much. Councillor Carey.
Thank you, Chair. Yes, regarding the 10.3 million ring-fenced misuse funding, over the next 12 months, what improvements should Scrutiny like to be seeing over the next 12 months? Thank you.
Yes, thank you. So the key areas that this additional funding is used to support, there are several areas. I'll just highlight some of the key ones. It's increased support for people who are in contact with any part of the justice system. So that could be police, probation, courts. We have several areas of work where we seek to get people who are in contact with the justice system into treatment, but we are expanding those. So particularly, for example, we're just doing some work with the police around testing on arrest. So we'd be able to enhance that work. And so if someone's arrested for an offence where it's perceived that drugs or alcohol were a part of the kind of underlying factor for the offence, then if they're not already in treatment, we get them into treatment. Obviously, the individual has to choose to enter treatment, but we work really closely with them, so it's not just about and this is one of the advantages of the funding, it's not just about a sort of a suggestion that you go to the service, but it's about a one-to-one conversation with that individual to help them understand what treatment's about, what treatment will offer them, and that we find with that we get much more likelihood of uptake of the treatment offer. Similarly, the same kind of offer for people who are at risk of rough sleeping or rough sleeping, it becomes about going out and having conversations. So over time, what we're seeing, because obviously this is a continuation with some small changes of previous year's funding, we've seen an increase in the number of people who are rough sleeping who are in contact with treatment services, which is great because that contact is that first starting point on their journey to recovery. We're always looking for new ways to be able to engage with that cohort, and particularly when we think about non-opiate drug use, so kind of things like, as I say, cocaine, ketamine, we're always looking for new opportunities, and this funding gives us an ability to be a bit more innovative in how we might reach that group.
Thank you very much. Councillor Cullen.
Thank you very much, Mr. Chair. I'd just like to make a comment regarding the case studies that have been attached to the end of the report, which I want to thank you very, very much for attaching them. And may I please request that items brought to the Scrutiny Committee in the future have similar additions put to them, as it brings I feel, a human face to reports, to agenda items, other than just percentages and statistics. So, yeah, thank you very, very much for adding those on.
Thank you. I think it's really important, especially for a service like this. It is complex, it is complicated what's on offer, and I think the case studies do help to bring it to life and, as you say, add the human dimension.
Thank you very much. Councillor Cook.
Thank you, Chairman, and thank you, Lisa, for your presentation. I found it was quite interesting actually hearing about the different uses of drugs. Essentially, you mentioned about ketamine, being much more increased usage across the county. And actually, when I quite often go on a police walkabout with our police down in Stamford and sort of in the south of the county, actually, cocaine is one of the highest areas where you see it from habitual people, but also you just know it's in the area, and I know that's one of the challenges we get in the south. So, just bearing in mind, obviously, we've got a beautiful county of Lincolnshire, but it is huge. And I guess this is one of the questions I always ask when we have these reports is, how do we make sure that everybody in this county, whether you are in a city, a town, or in a rural village, has the same level of equal access to these services? Because it is a difficult thing to organise in terms of managing it across such a huge geography. And I guess for us, it's just that assurance of everybody is getting the fair and equal treatment that we can possibly provide.
Yeah, thank you, Councillor Cook. I think one of the things, and this comes back to the point that was made earlier around kind of continuous improvement, one of the things that we've always been really keen with this service is that we have several hubs. We call them resource sites, so it operates from 7 places across the county, but that's only, lots of people don't live in those places. They're there as sort of a central base, but then it's really important that we do outreach into different communities. So the service will go out and spend regular half days or days in different communities using kind of other facilities that are available where we need it. We do also look at whether or not it's the right thing to do to have things like a travelling bus that would go out to communities. That works for some things, it doesn't work for other things. But we always look at the opportunities to deliver differently to make sure that we're reaching, or we're kind of as accessible as possible to everyone across the county. I think one thing that's also really important is that through this contract, and particularly through some of this supplemental funding, it's enabled us to develop much closer working relationships with other partners across the county who do have footprints in places we don't. So LPFT would be a really good example. We have we have a really good working relationship between the service and LPFT, particularly focused on providing support for each other for patients, essentially for clients with dual diagnosis, so where they've got co-occurring mental health and substance use needs. And that means, again, that we can sometimes be a bit more flexible in where we're delivering the support. Sometimes it might be online if that's appropriate, but it's really important that that good relationship is built up between the key worker and the client. And we're also always looking for new opportunities. So one of the areas that I am really keen to build up over the next kind of year or two is how closely we work with primary care, because they are in more of our communities again. Historically, substance use services and primary care worked very closely together, and you'd have what was called a shared care arrangement. We don't have so much of that nationally anymore, but recognising that primary care is really busy, also they are supporting a lot of patients, their own patients who have drug and alcohol treatment problems. So for me, there are still opportunities to make sure that we're even more available and kind of visible, if you like, within local communities. So there's several different ways, if you like, in which we kind of progress that work. Thank you.
Thank you, Lucy. Councillor Lee.
Hi, Lucy. First of all, thank you for a really good, thorough report, and thank you for all the work that you do. I live somewhere where this is a problem, and it's appreciated. There's a bit of this that, forgive me, it's not layman's terms, and you wouldn't expect it to be, but I wondered if you could go through it for me. At the bottom of page 77, there's a bit that says the decision in relation to recommendation 1 would meet the requirements of compliant with the council's obligations under the PCR. And it goes right down and it talks about modifications. And the final sentence that I can see was, I think it's the first, second, third paragraph down, and based on the proportionate values, the scope of the contracts will not change considerably. Now that's quite a subjective view. Can you tell me, can you just go through that in slightly easier terms and tell me how it's going to change?
Okay.
Yeah,
yes,
it's
I'll
just
try.
a bit complicated.
Thank you, yes. So what that section talks about is the procurement implications of the modifications that are proposed. So for the substance misuse treatment and recovery contract, because the potential for a change throughout the contract term, utilising supplementary funding, which we knew would come in future years, was built in from the outset. And the public contract regulations, which are some of the terminology you referenced there, is the prevailing procurement legislation that applies to both of these contracts, because that was the procurement legislation in place at the time that they were let. It's since been replaced by the Procurement Act, but it's still the public contract regulations that apply to these two, which is why that's been more explicitly referenced as part of this report. For that, it's an absolutely legitimate modification. There's no reason for this to be considered an exception to contract regulations, and there's no procurement risk associated with it. For the housing-related support service contract, there was no express provision made when the contract was originally established that foresaw this type of supplementary funding needing to be varied into it. However, the public contract regulations do make provisions for circumstances in which modifications to contracts are permitted beyond those where it's expressly noted at the outset. And one of those is where the nature of the modification is not considered substantial within the defined meaning of a substantial modification in those regulations.
Thanks. I think that makes sense. It's basically about you've got extra money coming in.
Yes.
Yeah, and let's hope, given recent announcements, you might even get more. You never know.
Yeah.
Thank you very much. Councillor Overton.
Thank you. I was also looking for some of the basics. So it's 10 million now. What was it last year? And this is the total amount, I think you're saying, 10 for this. And I see that it's reached, I think you said the additional funding has contributed to supporting 3,500 adults and 229 young people in 24-25. So how many people are we meeting? What is the unmet need, do you think? I really appreciated Lucy's comments about the work that you're doing to try and find people and help them to access the service. But are we touching the surface?
Yeah, thank you. So I'll take the first question was, I think, around how much were we spending last year. It wasn't all pulled together in the same way, but we were spending around about 9.4 million last year. So it's £1 million more that's been put into that ring fence, kind of that protected budget for 26-27. And then just in terms of the need that's out there, it's quite difficult for drug users to understand the need, but for both alcohol and drug users, there are estimates that are generated by universities, essentially. They look at lots of data around everything from kind of police records around drugs and alcohol through to who turns up at hospital with certain kind of end outcomes that might suggest they've been using alcohol or drugs in a problematic way. They work some magic and create a model essentially to estimate how many people we think are likely to be affected by things like drug addiction or opiate and crack cocaine use in Lincolnshire. From those estimates, which are a few years old, but they are the best we've got, we estimate that there are between 7,000 and 8,000 people in the county who are dependent on alcohol. So just for context, we've got 1,300 people in the treatment service who we would say are alcohol only. Obviously, some people are being supported for drugs and alcohol. But that gives you a sense of the need that's out there. Now, obviously, this isn't the only service that provides people support with those needs. So you do have organisations like Alcoholics Anonymous who will also provide support. Some people will support themselves there are lots of online forums and places where people can go now for support. So there will be people out there who are finding support for themselves in a different way, and that meets their needs. But that would suggest that there are still quite a few people out there who are dependent on alcohol who we're not reaching, and that's one of the reasons why our kind of wider prevention work with partners across the system is really important. For drug users, it's really hard to know, but we have estimates that talk about the number of opiate users, for example, and that suggests that we're probably reaching about half of them. So if we think about, we've got kind of over 1,000 people in treatment for opiate addiction. That's probably about 1,500. We're probably missing about half of them. So again, that's why it's really important for us that we do the wider work with partners, because actually they might be more likely to be coming across people who are dependent on drugs, who we can then support into treatment, and having that easy referral pathway in. People can self-refer in anyway. Anyone across the county can self-refer into treatment, but sometimes people need that helping hand, that nudge to give them the motivation to ring or kind of ask for help. So yeah, that just gives you a bit of an indication about where we are in that space.
Thank you, really helpful.
Very much. Councillor Woolley?
Thank you, Chairman. I suppose it's really a blunt question. How can we guarantee that we are treating Lincolnshire residents not just equitably, but it's that assurance around we're spending even more money this year than we did last year. How can I be certain that everyone you treat, particularly with drug and alcohol, tends to be within a transient population? So how do I know that it's not a significant number of people that are coming into Lincolnshire, because the quality of the treatment that they will receive is far and away better than the treatment they may have received in, say, picking a county out of the air, Nottinghamshire?
Thank you, Councillor Woolley. So we do occasionally get people coming to treatment who live out of area, and we'll work with them to go back to where they're from to receive treatment there, because drug and alcohol treatment is usually a long-term. For most people, they'll spend quite a lot of time in treatment, so it's most appropriate that you go into treatment in your home area. So although we do have a handful of people, and it's only a handful of people that might approach our services who, they might be perhaps here on holiday, for example, or visiting, actually it's a really, really small proportion of the people that would refer or self-refer in, and we'll support them back to treatment in their own area to make sure that it's Lincolnshire residents who benefit from our service.
If I can just come back to you, so that would mean that you can only work on a permanent address then. So how does that sit with homelessness, for example?
So it doesn't have to, someone has to have a connection to the area essentially. So for our for the work that we do with people who are street homeless, for example, they are often very well known to the local to people, to organisations working in that local community, and we work with those organisations who have that kind of trusted relationship to build up the relationship with someone in treatment. So I suppose there is a chance that somebody might move to Lincoln and be on the streets, and they might end up in our treatment system, but I think it will be very, very small numbers. But I'm also happy to go away and just get some numbers and some clarity on that, if that would be helpful, Chair.
Yeah, if you can do, please. Yeah.
Yeah, okay.
Lovely. Thank you very much. Thank you for your questions and comments. That now concludes the discussion on this item. Some of your comments will be captured by the Health Scrutiny Officer and will be shared with the Executive Council for consideration. I move that the committee has considered and scrutinised the report and that the recommendations to the Executive Council. Please raise your hands if you agree. Thank you very much. That is agreed. Agenda item 10, Adult Care and Public Health Scrutiny Committee Work Programme. This item is on pages 87 to 94 of the agenda pack. This item enables the committee to comment on the contents of the work programme. The report will be presented by Chiara Hattianu. Nearly there.
Spot on, Chairman.
Thank you very much, Chiara. Over to you.
Thank you very much, Chairman. So, good afternoon, members. Just a very quick introduction of the work programme that can be found on pages 87 to 94 of the report. Just to say that since the publication of this agenda pack, there have been no further changes identified. If you have any further suggestions to themes that have been discussed today and I have captured already to be introduced into the work programme work streams, please do liaise with me offline or raise comments right now if you wish to, and I'll be more than happy to capture those and work away with the officers in seeing them introduced into the work programme. We have a very, very busy September meeting ahead, and we will be updating the rest of the work programme for the rest of the year, as this is a living and breathing document. So thank you for that. No further comments. Thank you.
Thank you, Chiara. Do we have any comments at all? I was just wondering if Councillor Cook, would you be happy to put in the smoking pouches on the work programme at a later date, or?
Yeah, I don't mind. I think it was more, I don't know if it's going to be picked up in some other part of our work in terms of nicotine, but I mean, I don't know if we need a separate report on that or not. I'm looking at our professionals on this one.
I mean, I think we can bring a report on things to do with smoking at an appropriate point.
Thank you very much. Councillor Lee.
Chairman, I was going to speak and then decided not to. I was only going to say I used to work in coronary care and people have prescribed nicotine patches virtually straight, I don't mean like the minute they've had a heart attack, but very soon in the hours afterwards. So I think it is a question of weighing up the benefits and the disadvantages, if there are indeed any. But if they were dangerous in any way, I can't believe for a minute that they would be prescribed.
I think what you're talking about is different. So I'm talking about if you notice the pouch that people put under their lips, it's whether it's the oral. No, these are like pouches that go under. That goes on the gum.
It's pouches.
Yeah, and there's a growing trend of it, and you see it.
Yeah, lovely. Councillor Hume.
Very small thing to add to that. It's not nicotine itself that causes cancer. So when Martin Samuel noted things to do with smoking, that would be brilliant to see that and the data on that, because whilst nicotine is not good, it does accelerate if you have cancer. It doesn't actually cause it itself.
Thank you very much. Martin.
The other Martin here has nudged me to note to remind you that we have tobacco smoking and smoking cessation on the agenda for the 16th of December already.
No worries. Thank you very much. Can we add that about the pouches into that as well? Thank you very much. Thank you for your questions and comments. This now concludes this discussion on the item. I move that we approve the planned works programme for 2026 and beyond, subject to the consideration of any items being highlighted today. Can you please raise your hands if you agree? Thank you very much. That is agreed. That now concludes the business of this meeting. Thank you for everybody and your attendance.